rarely discussed hepatology. I'll request the chairpersons to join us on the stage. Dr. Aditya Kaye, Dr. C.R. Panda, Dr. Anup Saraya, and Dr. Pradipta K. Sethi. Please join us on the stage.
Aditya, Madhu नहीं था ना? अरे यार तुम लोग कौन से? And very interesting session again. And for the fast talk, I would like to call Dr. Madhunil Niriela from Sri Lanka, Colombo. So he will be talking about assessment of concomitant non-liver alcohol syndromes in patients with ALD and their impact on outcomes. Dr. Niriela, please.
Good morning, ladies and gentlemen. First of all, I'd like to thank the organizers, especially Dr. Akash, for the kind invitation to come and give this talk. My topic is concomitant non-liver alcohol syndromes in patients with alcohol-associated liver disease. Due to time restrictions, I will talk only on alcohol use disorders. I have no disclosures, financial disclosures, but I must disclose that I am not a psychiatrist. But I think this is a very important topic in managing our patients, and we should all know how to manage and assess patients with alcohol use disorder in our patients. So in the next 15 minutes, I'd like to talk about the scope of the problem, the pathophysiology, clinical assessment, prognosis, and brief outline on the management. Alcohol use disorder is a chronic relapsing remitting syndrome in which excessive drinking of alcohol persists despite causing health and social problems. AUD is a leading contributor to illness because alcohol contributes to more than 200 diseases and injury-related health conditions. And it also leads to death globally. It's the 7th leading risk factor for premature death and disability, especially among the productive young age group. AUD is frequently overlooked, not diagnosed or treated in the clinical setting, unfortunately. As a result, the burden of disease remains high. Alcohol causes the most harm compared to other substances, although a fairly old study from 2010 from the UK, this clearly shows that alcohol causes more harm to the user and harm to others than any of the other substances. When we talk of alcohol-associated liver disease, it is 2 diseases, not 1. It's a combination of chronic liver disease plus alcohol use disorder. We have to treat both if we are to make a real impact and improve survival in our patients. There is an enduring myth that alcohol use disorder results from a moral failure, and this myth continues to influence the public and professional views as well. At an individual level, the estimated risk for an individual is about 50% is inherited. Mental health disorders are associated with double the risk of AUD. And adverse early outcome life experiences and trauma in adult life also increases the risk. From a public health point of view, ready availability of alcohol at a low cost and widespread outlets are additional important risk factors. Consumption of alcohol activates the reward regions of the brain, increasing the release of dopamine and as additional involvement of endogenous opioids, GABA, and endocannabinoids. And these reward systems project to the orbitofrontal cortex and provides a pathway for alcohol to influence decision making, including reduced inhibitory control. With repeated exposure, neurotransmitter responses are blunted in the severe forms of AVUD, and increasing doses of alcohol are needed to produce the same effects, what we call alcohol tolerance, and alcohol withdrawal emerges when high levels of consumption are reduced or ceased abruptly. Unhealthy alcohol use is a spectrum from abstinence to low risk use to risky use to problem use to moderate substance use disorder to severe substance use disorder. From none to very heavy alcohol consumption, we have none to very severe consequences. How do we define alcohol use disorder? It is defined by the DSM-5 diagnostic criteria. There are 3 broad domains and 11 diagnostic criteria. In the first domain, impaired control, there is 4 diagnostic criteria. In the social dysfunction and physical risk domain, there are 5 diagnostic criteria. In the physical dependence domain, there are 2 diagnostic criteria. So altogether 11. If there are 2 of 11 within a 12-month period, we can diagnose AUD. And depending on the number of criteria that are present, we can categorize the severity: mild 2 to 3 criteria, moderate 4 to 5 criteria, and severe 6 to 11 criteria. How do we assess? When appropriate, a quantitative alcohol history should be recorded by healthcare professional because the risk of medical complications such as cancer and liver disease are related to the average daily consumption. A history of alcohol withdrawal and intoxication should be sought in all our patients, and common associated physical signs should be looked into: overweight, obesity, hypertension, and stigmata of chronic liver disease. Systematic use of screening instruments in our clinical practice increases the detection of AUD, and the WHO endorses the audit screening, the alcohol use disorder identification test, which is sensitive and has been implemented in various clinical settings. There are 2 forms, an interview and self-reported. Both versions, there are 10 questions on a scale of, scored on a scale of 0 to 4. Higher scores indicating greater use or problem use. A score of 8 or greater is considered to be indicative of hazardous alcohol use or alcohol use disorder. At least in our busy clinical practice, we should use in our clinics at least some of these brief instruments, if not for audit. So we have shorter versions like Audit C, which can rapidly screen the quantity of alcohol use. We also have the 4-question CAGE questionnaire, cut down of drinking, annoyed by criticism, guilty feelings, and eye-opener screening. 2 or more affirmative answers suggest the presence of alcohol use disorder. Occasionally, sometimes, most often actually, patients do not accurately report their alcohol use. So we have to always take a collateral history from a patient contact or look at the past medical records, which may be helpful. Occult alcohol use may be revealed by periodic re-evaluation and also observation in an alcohol-free hospital environment. A little bit more on the Audit C, which we use very often for our patients. There are 3 questions, again scored between 0 and 4, a maximum score of 12. 3 simple questions. How often do you drink, have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on any occasion? So out of this 12 possible maximum score, for females, any score more than 2, and for males, any score more than 3 is positive for risk drinking or alcohol use disorder. Biological markers also play an important role in detection of recent alcohol consumption as well as monitoring of ongoing alcohol use during treatment. We know that liver enzyme concentrations are widely available, but it's limited by the sensitivity and specificity for detection of alcohol use in our patients. Most sensitive probably is gamma GT, but unfortunately these levels, gamma GT levels, are increased only in about 50% of patients, males with alcohol use disorder. It is even lower in among females as well as younger people. An elevation of gamma GT can occur due to other non-liver related conditions also. Detection of ethanol itself in the blood, breath, or urine reflects recent exposure, but is only positive for a few hours after drinking. So it's useful in the ED setting to confirm recent alcohol use. Non-oxidative alcohol metabolites are emerging as a clinically useful biomarker for alcohol use. especially PET or phosphatidyl ethanol, is a conjugate of phosphatidyl chlorine and ethanol. It's present in red cells for several weeks after drinking. So therefore, we gives a window of about 1 month. And a negative test in this context is very helpful for confirming abstinence. Carbohydrate deficient transferrin is also useful, but is less sensitive and specific than PET. We also should examine for coexisting conditions. Substance use disorder is the most common coexisting condition with AUD. Smoking is the most prevalent. We must look into mental health conditions occur in many, mostly in women. Look for anxiety and depression, externalizing disorders, increased suicidal risk, especially in the early disease. There are lots of social problems in our patients, lack of employment, occupational safety risk, housing and relationship issues, as well as legal complications. Please do consider mental health care in the management plan of your patients and engage specialist mental health services whenever appropriate. What about prognosis? We all know that alcohol abstinence is key in our patients with chronic liver disease. When it comes to patients with chronic liver disease, there is no safe limit. Abstinence is the best. If we take alcohol-associated hepatitis, here is the long-term impact of abstinence, clearly showing that complete abstinence is better than those who went back to drinking. Here is data for patients with alcohol abstinence showing improved prognosis across all stages of portal hypertension in alcohol-related cirrhosis. Abstinence is linked to reduced decompensation, improved survival, regardless of the portal hypertension severity. And this meta-analysis, the most recent one on the impact of alcohol abstinence and alcohol-associated cirrhosis, clearly demonstrates improved survival. Coming to management, there are few key principles. Treatment is generally effective but is underutilized. Person-centered, non-judgmental approach is essential. Treatment plan should be negotiated collaboratively with the patient. Consider cultural and racial factors in the recovery support. Account for practical limitations such as cost and the local availability of services in your setting. Natural recovery is possible without formal intervention, but this is rare and is usually in a minority. What about psychosocial treatment? Brief interventions are very helpful, structured, time-limited, advice, 1 to 3 sessions, 5 to 20 minutes each. It can be delivered by us non-specialists. It includes personalized feedback and motivational interviewing, can be delivered via phone and online as well. This motivates patients to start medication and specialized treatments. We can enroll our patients in peer support programs such as Alcoholics Anonymous and SMART or self-management and recovery training methods whenever it's available. I'd like to spend a little bit on brief intervention or the flags approach to brief intervention for AUD. Give feedback to about the personal risk and the consequences associated with drinking. Listen to the patient's responses. Give specific advice about the importance of changing the current drinking pattern in a non-judgmental tone. Discuss the goals of safe drinking limits and assess the patients and set goals for changing the drinking pattern and negotiate practical strategies to reach agreed goals. There are other psychological treatments, cognitive behavior therapy, other approaches like motivation enhancement therapy, acceptance and commitment therapy, mindfulness, which are also helpful. What about pharmacotherapy? Briefly, 3 FDA-approved drugs. Disulfiram cannot be used in our patients, contraindicated. Naltrexone and acamprosate can be used in compensated patients, but not in the advanced CTP-C patients. There are 3 non-FDA-approved agents, baclofen, topiramate, and gabapentin. Probably baclofen and topiramate can be safely given to patients who are compensated, and it can't be given to patients who are having advanced liver disease. So, chairpersons and ladies and gentlemen, in conclusion, I'd like to give this few key takeaway points. A quantitative alcohol history should be recorded from all our patients with alcohol-related liver disease. because alcohol contributes to many physical and mental disorders, not only the liver disease. A person-centered, non-judgmental approach should be adopted for all our patients. We can deliver brief interventions very effectively, and we should know how to do this. Pharmacological treatment is effective, but is underused. I encourage you to use these drugs whenever it's possible. Get the help of specialist services and offer comprehensive care, including psychosocial interventions, because it helps to address both the alcohol and the liver disease in a multidisciplinary setting. And follow-up is recommended owing to the relapsing and remitting nature of this disease. Thank you.
Thank you, Dr. Madhuri. Please come and join us here. We'll take the question at the end of the session. Now I would like to invite Dr. Niketi or M.I.C.E, and he'll be speaking on recent advances in management of hepatobiliary parasitic disorders.
So I will use this one.
Yeah, you can use this. I'll just give you access on this.
Yeah, this way.
So you can use the ticket, you can use the tickets.
This one? I'll use.
What is that? You can use yours, you can use
You make it bigger. Okay. No. Okay. 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 Can this one? Okay. Distinguished chairmen, distinguished experts, ladies and gentlemen. First, I would like to thank to Dr. Akash Shukla for inviting me to this very important meeting. So my task is today percutaneous treatment of hydatid cyst and the Urmacı technique. Sorry. Go back. No. Yes. Okay. So echinococcosis is a disease caused by larval form of Echinococcus granulosis. Its adult form is almost 3 to 6 millimeter long and is 0.5 millimeter broad. It has a 3 to 4 proglottis. Parasite inhabits in the jejunum of the definitive host like dogs, wolf, or other carnivores, and it releases the thousands over and which are then passed into the feces. So this is a very important health and economic problem because already it costs almost $3 billion US dollars every year. As you see in this picture, the red colors almost invaded in all the world. So human being just accidentally get this disease. The ova, unconsciously, if the human being get the ova, then ova will just open in the jejunum and the larva occur
larva or perforate the bowel wall and then go to portal vein, go to liver, and locate it there. Generally, 70% of those parasites located in the liver, but almost 20% of the larva also located in the lung if passed through the liver. When we look at the patients, generally they don't have symptoms, important symptoms, so they just slowly by slowly growing up, and finally every year 1 to 3 centimeter in diameter, but after 10 years there will be huge lesions and compressing many vital organs. So the diagnosis of hydatid disease just can be done the hemagglutination inhibition or latex agglutination test, and the immune blotting test at the sensitivity almost 85 to 98%. Specificity is low. Generally, without any symptoms, the patient come any other symptoms or diseases, then we accidentally do diagnostic ultrasound examination and diagnose the patient. But sometimes if we suspect and we didn't diagnose by ultrasound examination, then we can apply to CT or MRI examination. And the definite diagnosis, when we puncture the patients, we can see, as you see here, rock juice, and we can definitely understand that this is a hydatid disease. So sometimes there will be a connection between the cyst and biliary ducts or vessels. Then in those cases we just do MRCP findings, and it shows here the relationship between the hydatid disease and the vessels. In our research, the sensitivity of MRCP was 91% and specificity was 82%. Generally, at the beginning, we just used macrolide albumin and injected into the cyst, and in order to diagnose is there any connection between the hydatid disease and the vessels. So this macrolide albumin diagnostic rate of fistula by ERCP 12.5%, but macrolide albumin was 15.4%. As you know, there are many complications of hydatid disease, local or systemic. So intrahepatic complications, exophytic growth, transdiaphragmatic thoracic involvement, perforation, infection, involvement of the more distant anatomic sites such as muscle, bone, spleen, and the lung, some others. You see here, open the common bile duct. Here, just complicated the stomach, opening the stomach. Here, just common bile duct again, you see, during the ERCP. We just sphincterotomy. And then germinative membrane came out and we cleaned the common bile duct. So in this case, just the hydatid cyst opened the gluteal area. So when we look at the therapeutic options in hydatid disease, there are 4 main therapeutic effectiveness: surgery, medical, or percutaneous, and watch and see and watch. If you talk about the percutaneous treatment, PAIR, PIVAC, or MOCAT, or Urmacı technique, or rarely we can see the literature, percutaneous mebendazole or albendazole injection into the cyst. So aim of the surgical treatment of hydatid disease, just relieve symptoms, inactivate and completely remove viable scoliosis and germinative membrane, and manage the residual cavity. But the percutaneous way almost serve the same aim. When we look at the benzimidazole carbamate, mebendazole or albendazole, just they have a limitation. Almost 1/3 of the patients may have effective. So small cysts can be done, can be cured by the mebendazole or albendazole, but of course albendazole is better than mebendazole. Surgical treatment, okay, is very good treatment, but there are some, unfortunately, negative points. Morbidity higher, 32%. Mortality in some centers 0 to 8%. Recurrence in against some centers 20%. Hospital days are longer than the other percutaneous treatment, expensive than the percutaneous treatment also. So I don't want to talk about the pair technique. I think most of you you are familiar to pair technique and catheter technique. So when we look at the results of pair technique, totally almost 2.94% major complication. But if you use catheter, then in those patients, complications increased and 36.84%. And the minor complications, of course, 58% and 60% with respective pair or catheter technique. In our technique, we just use the patients by ultrasound under the ultrasound examination, but especially type 2 or 3B, we just try to inject several needles at the same time with different daughter cysts into the different daughter cysts. You see in the picture, we have punctured almost 6 or 5 according to the diameter of the cyst. This is muscle cyst again, two injection at the same time. You see in type 2, we just punctured at the same time several needles, and every local, every daughter cyst can be cured at the same time. You see here. So another one. So this is kidney hydrated disease. The last week I treated these patients. After injection, polydocanol and the pure alcohol, then germinative membrane just detached and became very whitish. So there are several differences between pair technique and the Ermege technique. We use generally a thin needle, 22 gauge, and just less amount of juice we aspirate it, not more than 40 cc. We use polydocanol together with pure alcohol. Polydocanol was used the first time among our group. So we don't use any catheter, and just 5 minutes we wait and take off the needles, that's all. And the outpatient basis, this is this treatment, and no chemotherapy. We never use the chemotherapy because chemotherapy also has some side effects on the liver, as you know. So if we don't satisfy this treatment, then next 2 or 3 months we can repeat again and then just try to cure the patients. So at the same time, 1 to 5 punctures, we can inject the polydocanol and the pure alcohol. There are some tricky points, as you see in the slide. The inside of the hydrated cyst, high pressure, almost 30 to 80 centimeter water. But in the pair technique, generally they evacuated all the juice. That means they just the pressure became zero almost. But in those cases, bile ducts pressure 20 to 25 centimeter water. So from bile duct to cystic cavity filled up by bile. You see. Okay. In the cases, garbage type 1, 2, 3, or CE1, 2A, 2, 3A, and 3B. Contraindications, generally inactive or fully calcified cysts, we don't see it. The cyst known to have overcome communication with biliary tract. But this is another advantage of my technique, because the polydoconal especially just close the connection between the cyst and biliary levels or the other vessels. So because of that, okay, I use this one. There are several criteria for cure. Anyway, we have diagnosed 1,556 cases and treated 889 hydrated disease. Mean follow-up almost 60 months, and the overall success rate 94 points. When we look at the complications, our success rate is almost 91.33, especially type 2 and the 3B. If you look at the literature, the catheter success rate less than 40%, but our success rate 91%. Complications also very less in our case, and 4.2% and 5.1%. But when you get the literature, major 36.84 and the minor 60%. These are several examples. Type 1, just during the therapy, before and after, as you see, became solidified. This is type 2, after treatment becomes solidified. Type 3B, after that solidified. This is huge hydrated disease, just located in the right lobe of the liver, and they're just communicating with the lung. After that, becomes very small inactivated cyst. This is a spleen hydrated disease. This is a muscle hydrated disease after that solidified. There are several reporting about these topics. Okay, when you look at the comparative study, this is surgical technique, and if you compare the surgical technique and the pair technique, of course, pair technique much more successful, less complication, and less hospital stay. So, Mr. Chairman and experts, dear colleagues, this is according to conclusions. Örmece technique is effective, safe, easy to perform, cheap, repeatable, and they should be the first choice for the treatment of non-complicated hydrated cyst. So, APASL single topic conference in 2025 will be in Istanbul, and also APASL annual meeting will be in Istanbul in 2026. So it's my great honor and pleasure to invite all of you. Thank you very much.
Thank you, sir, for an excellent talk on hydrated of liver. Please join us for question session. Both the topics are open for questions and comments. Any questions or comments for both the topics?
I think we'll request Professor Patrick Kamath to summarize all that we have done today, and then we'll have a discussion on those points.
Okay, thank you, Akash, and The way I thought I'll go over it is I'll summarize each talk, at least as I understood it, and maybe I have a question for the speaker, and then we can have a chance for the audience to ask another question, and we'll just make it very brief and we'll go down all the talks. So hopefully by the time the session is ended, you'll get, a good summary of everything that was decided. So the first talk was Jacob George. I hope Jacob is here. Okay, so that makes so Jacob's talk was on cardiovascular interaction with MASL. So points to take home is number one cause of mortality is cardiovascular in these patients. Two, steatotic liver disease, you get meta-inflammation, so you get multiple organs involved, and that's the basis for several other problems that occur. Three is assessment of cardiovascular risk. I have a little disagreement with what Dr. George said, at least what he reviewed, that steatosis independently is not a risk factor for cardiovascular disease. So we have a hepatology paper for my colleague in our community, and if you follow these patients, especially women, it is a risk factor for cardiovascular mortality. So there's a cardiovascular risk factor calculator. In postmenopausal women, at least we don't think it works that well because women are supposed to be protected. They get a lower risk, but if they have steatotic liver disease, they lose that protection. So yes, we do believe that steatotic liver disease independently is a risk factor for cardiovascular disease, especially in women. So what should you tell all your patients? Message is very simple, something which your grandmother would have told you. Eat healthy, exercise regularly, 150 minutes per week, do some resistance training in there. Statins, I just look for an excuse to put patients on statins. So statins are good. It's not a problem in these patients. I think the knowledge gap here is what do you do for cirrhotic cardiomyopathy? I think GLP-1 agonists are likely to be helpful, but that is something that needs to be studied. And, maybe Ajay, in the absence of Jacob, do you want to make some comments on cardiovascular risk, especially with the Indian population, especially with the BMI being quite different, the increased risk of cardiovascular disease, the role of ApoA in these patients? Do you want to take that? Just some simple take-home messages regarding cardiovascular risk assessment. And also because you have a leading role here, how should we manage MASL? Who should look after them? I think it's less the hepatologist and more the primary care, but your thoughts? Anyone from the panel want to take that?
Yeah, thank you. So I think we've done some work with the connection between MASL-D and the cardiovascular disease. I think 15, 20 years back, we had looked at this carotid intermedia thickness and the brachial artery stiffness and all, and then we thought it was all connected. But then recently what we did was we did two cohorts of patients. One was the MASL group, I think a large number, and then we also looked at the coronary angiographically proven CADs. So in coronary artery proven CADs, when we looked at MASL-D, a large number of them had steatotic liver disease. But on the other hand, when we looked at the MASL population and tried to look at how many of them actually have cardiovascular disease, we didn't find many. And in conclusion, what we said was this is the severity of liver disease again, which probably determines the occurrence of cardiovascular disease. So maybe this may be a little paradox. We know that as you said, that the most common cause of death in early part of steatotic liver disease is not liver, it's cardiovascular. But then, as I said, in the early part of the liver disease, we didn't find any much of coronary proven cardiovascular. I think that's what. The second point, which is very relevant for the clinical practice, is that whom to screen for cardiovascular, we really don't know. It's really practically not possible to screen every patient with fatty liver disease for cardiovascular assessment. So I think that risk stratification is also very, very important. And again, I said in our APASL guidelines also, we said either it has to be done on case-to-case basis, or those who have other metabolic risk factors, especially diabetes and obese people, then maybe you can stratify. It's probably not possible to screen everybody for cardiovascular disease.
And is the physician population in India getting more versed in how to manage these patients, because ultimately they are seeing the burden of this disease? Jacob, I wanted you, but in your absence, Ajay answered the questions of who should look after these patients. Are you suggesting reorganization of practices? Because I don't feel comfortable as a hepatologist to look after all these cardiovascular and diabetes problems. So who should look after these patients in the absence of advanced liver disease?
I think the issue is that we need metabolic physicians, and currently it's too difficult to actually change our models of care because we all look after our individual specialties. But I think from a patient perspective, yes, if you've got an educated primary care workforce that are following guidelines, but even in Australia, what I've actually found is that for the information to percolate down to the general practitioner about, the targets that you need to reach for lipids, HbA1c, blood pressure, they don't actually always follow it. So the one thing I'm confident about doing is looking at the risk stratification for lipids and to treat and titrate the lipids to get to those target levels. I think one of the big changes that have happened recently is that we know that treating to target markedly reduces your risk. So I try and do that. Patients with an HbA1c of less than, we want it to be less than 7, particularly in the first 10 years of diabetes. And if I feel uncomfortable to treat those patients, what I tell them in the letter to the GP, I say, we need to actually get this diabetes controlled better to less than 7. So the key take-home message is knowing what your targets are. Same thing with blood pressure. If you don't feel confident to treat blood pressure, that's fine. But at least tell the primary care person or the other individual, this is the target. And that's the way I approach it, because we can't avoid not being metabolic physicians and not knowing the key risk factors and the key targets.
Thank you, Jacob. I think we'll move on to the next paper that was Puneet's talk. And Puneet, a lot of new terms, ferroptosis, inflammasome, apoptosis. Which are the ones that you think are most targetable? And the biggest concern is all these mechanisms also help prevent cancer. So if you block them, there's the potential risk of increased malignancy. So which do you think are the most targetable?
I think that's a great question. And the overall role of each of these pathways is very difficult to dissect in terms of the importance. However, apoptosis, as I said, has both a balance of protective or as well as harmful. And apoptosis certainly does favor, like in cancer prevention. So if one were to target in terms of minimizing the risk of disease progression as to like where apoptosis is beneficial in treatment or prevention, then apoptosis would be one target. However, in promotion of fibrosis, which is largely driven by the inflammatory response, both pyroptosis and ferroptosis assume greater importance in disease progression and fibrosis progression.
Just as an extension of that, you quoted that paper from Italy on curcumin. I handled the paper for another journal. In general, anything that is too good to be true It's probably not true. I was not convinced at all that 26 in each group. The reduction in kidney disease, 50%. That's sort of almost unbelievable. So any comments?
Put me in a tough spot because I was also the reviewer on that. So I thought and I agreed, initially also I had a very tough challenge in accepting the values, but I had further questions. And I feel the information from what the data were presented were convincing enough in terms of improvement response. Now, this particular phospholipid or phosphorylated curcumin has a greater absorption and was there was no mechanistic study that was showing what was the impact. The reason I used curcumin was because it is one of the pathways that could be used for ferroptosis. Most of the other trials without this particular compound have not demonstrated histologic or other organ benefit. So I do not know what would be it appeared to be very convincing, small number. So there is a potential for type 2 error in statistics.
Thank you, Puneet. Next was Ajay, back to you again, or should I ask Jacob to answer this question? I'll give it to you. So this is very common scenario. Patient brings a family overweight. They say they've read a lot, they've Googled, they say some cognitive dysfunction. How do you approach these patients? Very briefly, what are the tests that you do? Try and figure out, because is this overt encephalopathy? Is it sleep apnea? Is it inflammatory? What is happening here? So, and some of them may have alcohol too. Is it microvascular disease? So very quickly, what is your approach?
I think the quick answer to that would be the first would be to look at the severity of their liver disease. If they already have advanced liver disease, maybe cackled or cirrhosis, I think then the story is probably different. And then we probably need to work them up for M.I.C.E, the minimal hepatic encephalopathy, and overt HE and all that stuff. But if they are non-cirrhotics, or if they don't non-fibrotic fatty liver disease, or maybe minimal fibrosis, then they are complaining of these symptoms, then as I said in my presentation, I think we still do not have any guidance or guidelines on that. We need to do that on case-to-case basis. And for them, I think maybe psychometric test, maybe psychometric test, normally what we do for M.I.C.E could be digital test, or symbol test, or number connection test, or something those could be done, which may give you a little better idea. Even the ammonia estimation may also not be a bad idea. Some of the, the audience was pointed out, but this, as I said, has to be done on case-to-case basis. But then the first thing, as I said, would be the severity of liver disease. And even within the non-cirrhotics, this all cognitive dysfunction would depend upon the severity of liver disease.
Yeah, no, I agree there. And you can ask questions in between. I don't want to sort of monopolize this, but I'm just trying to finish the session here. Then Ashwani on drugs. So Ashwani, just today online, the JAMA paper that, the multi-center trial from Europe on simvastatin and rifaximin has come out online today. And that was a negative study, did not prevent complications in there. Question is, there are a lot of people here who are going to do trials. And so what are the specific endpoints you're going to tell them in a study with, say, MET-ALD? What should be your primary endpoint? What should be the secondary, so that they can design studies? Because I'm not completely convinced that what we decide in the West would also hold good here. I think they should do some studies here.
I think that's a great question. Part of it I alluded to in the presentation. So if it is a non-cirrhotic early disease, if you want to study MET-ALD of that group, I think change in liver stiffness, 20% this way or that way may be a good endpoint. For advanced F3 disease, maybe progression to cirrhosis would be a good point, if 2 or 3 years of trial or 5 years of trial. For cirrhosis patients, if you are if you're taking CAC-LD in the group, maybe progression to CSPH, maybe a good endpoint. You're already taking CSPH patients, then maybe decompensation and then mortality and liver transplant, maybe good endpoints. But more important materially in my mind is associating these outcomes, liver outcomes, with alcohol. And that's where I think more data is evolving. But in the context of clinical trial, I think this is an opportunity to associate whether alcohol use associates with improving liver outcomes. Because we don't know when we see these patients, and all of us, including you, when we see these patients, they say, can we have, say, 1 glass of wine maybe once in 2 weeks or something? And I don't have the answer to that when it comes to more and more data is evolving, that even less than 20 grams in MASLD is probably harmful in this population. So I think that'll be an opportunity to learn what is the safest level of alcohol use in this population. And obviously metabolic endpoints and patient-reported outcomes will be important.
Again, question to you only, a quick question and answer. So you talked about the genes. You know, there are specific genes which are identified for the alcohol use disorder, and there's a certain couple of genes which have been identified for the risk of development of liver disease in those who have alcoholic use disorder. Do you think it is in realistic future possible to have a gene therapy for treatment of alcohol use disorder and for alcoholic cirrhosis?
For the alcohol use target, I think there is no, at least in my mind, there is no homogeneity in terms of, for example, ALDH2, aldehyde dehydrogenase 2, or whatever these genes are driving alcohol use. The data is very heterogeneous, and I don't think there is any homogeneity in the database to conclude that these could be targeted to improve alcohol use. This is one-liner answer. For alcohol-associated liver disease, in my mind, the PNPLA3, for example, whether it is heterozygous or homozygous polymorphism, it does predispose to more advanced liver disease. I'm not aware of any studies targeting PNPLA3 or clinical trials, but the one I showed from GSK is targeting a protective gene polymorphism, which is HSD17B. And I think the company is trying to take patients who are wild type patients with ALD and kind of using a small molecule RNA to induce polymorphisms in those as a basis and see whether that improves the outcome of these patients or not.
Okay.
Two trials.
Thank you. SP, you have a question?
So, Patrick, you involved in the trial of interleukin versus corticosteroids. Most of us are not using corticosteroids anymore. So both of you are there.
So I'm moderating. You have to ask the speakers.
I think that's a very valid question, Sri, on steroids. In the context of Indian population, and I think I can quote JP Arabs, we were involved also in that retrospective study, and Patrick was part of that study, where we looked at not only the lower MELD cutoff, where the steroids are effective, which is 21, as we all know, but we also looked at the ceiling where they lose their efficacy or becomes futile to use steroids, and we found a cutoff of about 39. And I think in the Indian context, I totally agree with you because the disease is much more severe, much more advanced. Their discriminant functions are like 100 plus. When they come in, MELD scores are 40 plus. So the second point, if we talk about the Western world, and there was a trial published in JHEP last year in June, July, which was part of the Alcoholic Network Consortium trial of anakinra, where anakinra was actually more harmful. But what was interesting in that trial was that the steroid arm had only 9% mortality. So the only difference between that trial and the previous trials of steroids is that this is one of the trials which used, even STOP-AH did not use Lil-based, guidance of steroid. Yeah. So at 1 week, you stop the steroids. And that trial published in JHEP actually used that. So if you use steroids and guide your therapy based on Lil score at day 4 or 7, You will probably be right.
Okay, we've got 8 seconds left. I'll finish 3 papers very quickly. Dharmesh, very important. Remember, there are scores, but the experienced clinician knows that the scores don't always help. So you have to have a high risk, high suspicion for these diagnoses. Those who want to reach more about HLH, this week's NEJM review is on HLH, so you can do that. Important about alcohol use disorder, Dr. Nirela is in there. Use an audit score. Ask every patient, no matter what they come for, ask them for alcohol use. It's treatable. 2 or 3 weeks ago, NEJM review on alcohol use disorders, again, reading material for you. And finally, on parasitic disease, Dr. Ormich, I thought that was very interesting. So points to consider, there are various treatments, surgery, aspiration, albendazole combination. Know exactly when to use each one of these, okay? And with that, we end. Thank you so much.
A big thank you to the experts. That was a beautiful wrap up of the session. Thank you to the speakers and thank you to the panelists.